Good morning, team. YouTube, Instagram. Thanks for joining, whether it's live right now, a cup of coffee out here on the West Coast, or catching the recording. My name is Paul Killorn. Super excited to be the division lead for our brand new dry needling division. So before we dive in, I'll keep it short, but we are super stoked to really do our full-blown launch for the dry needling division this year. We already have 25 dates on the calendar, and we're just getting started. Whether you have training in dry needling and want to learn the E-stim piece, or it's your first dry needling course, it's really our goal to hit the safety aspects, but also how to specifically use it and strategically use it in the clinic. And again, a big piece of that is the E-stim. So if you're looking for some dry needling training, adding that to your practice, find a date this year. Otherwise, personally very excited because we are building a pretty impressive faculty. It's pretty streamlined right now, just a handful of us, but by the end of 2023, really want to build this division with bigger plans 2024, which includes an advanced dry needling course, which is the perfect segue because if you saw the title of today's episode, I'm going to talk about tendon needling, tendon dry needling. And if you do dry needle and you brought this up on your level 1 or your level 2 course, really, no matter where you were trained, you were probably given a pretty abbreviated answer. Whether it was supportive or not, they probably said, yeah, I needle tendons and it's great, or no, I don't really needle tendons. But either way, it's a fairly punctuated, a fairly short explanation. And to be fair, that's because there's a pretty small data set that goes along with tendon needling. Not to get ahead of myself, but the research set is actually there. So when I say data set, I really mean there's not many US dry needling organizations, educational organizations, that are teaching tendon needling. So today I'll give you my bias. I have been, early on I was trained in tendon needling. I did it for a little bit. So really today I want to give you the case for dry needling tendons and the case against it. And I'm going to try not to infuse my bias, but obviously a lot of this is based on my personal experience. So first of all, to paint the picture, to set the stage here, when I say tendon needling, there is there's a litany of research on dry needling for tendinopathy. A lot of those are still using intramuscular techniques. So dry needling gastroc and soleus, mid-muscle belly for Achilles tendonitis, the quads for patellar, glutes for glute tendinopathy. So that is not what we're talking about today. To be very specific, when I say tendon needling, our tissue target with the needle is either mid-substance, the collagen, mid-substance of the tendon, or the osteotendinous attachment. So, I mean, in research, but also clinically, we're typically talking Achilles tendinopathy, patellar tendinopathy, and really patellar ligament. We're looking at that lower attachment, tibia to patella, and then the forearm extensors, so lateral epicondylalgia. Some of the less common ones in research and clinical use are wrist extensor tendons, shoulder, so rotator cuff tendons, maybe the pubic attachments of the adductors or the abs, but tendinous attachments at the pubis, high hamstring or distal hamstring, and then actually needling the glute tendon or the biceps tendon. So again, to be very clear, we're talking right now about putting a needle into non-contractile tissue, into mid-substance or osteotendinous attachments, which, whether you're trained or not, or have tried this or not, that means the narrative for the benefit is very different than if we're treating muscle belly, which is, again, to paint the picture of the landscape in the US, 95, maybe even more, 98% of what is being taught out there right now is intramuscular, whether you're using E-stim to generate a motor response, whether you're looking for a twitch response, whether you're spinning or twisting a needle to grasp intramuscular traction. Almost all of the education out there is intramuscular, muscle belly, muscle spindle. This is not that. So as soon as I say our tissue target is the tendon itself, the narrative changes. And again, this is what I'm going to use to paint the picture for both the case for needling and the case against it. Because as soon as we say we're not looking to interact with a muscle spindle, I'm not looking to generate a motor response or contractile response with e-stim, the immediate question is, what's the goal of putting a needle in there? And I'll give you the rationale that I was taught first. And really, this mirrors the research at the time. This is earlier dry needling. 2010 was when I first was trained. We did a little bit of tendon needling. And the narrative at that time was we intentionally go in with our needle to produce micro trauma. So in research, you hear about tendon fenestration, or even it's almost like the periosteal pecking, but obviously we're in a tendon. But the goal was to intentionally traumatize, intentionally disrupt tissue with the response desired to be the body's natural healing response. So collagen resynthesis, tissue remodeling, angiogenesis, and localized blood flow. So we went into the tendon, picture that Achilles tendon, you went into either the osteotendinous insertion or mid-substance, and you gave these teeny tiny little pecking maneuvers with the goal of stimulating a small, a controlled inflammatory response, which would ultimately lead to a healing cascade. So that was the narrative I was taught at the time. To give a greater exposure beyond my own experience, at this point, depending on who you talk to or how you were trained, there are other narratives for tendon needling. Some just put a static needle and they talk about the local erythemia, the erythemic response, the blood flow response to just placing a needle in the tendon and letting it sit. You can put a needle in and then do the axial twisting and spinning, which originally was kind of tissue grasp, but is modifying into nervous system input, which I like. And we're also seeing more of the e-stim in a tendon. Again, that wouldn't be a contractile response, but we can stimulate the tendon and again, either see localized cellular and blood flow changes, or we're getting cortical input, just not through a muscle spindle, it's through the tendon. But again, all of that to say, everything else that we normally explain to a patient, everything from what it's going to feel like, this is going to be achy, crampy, sore, it might twitch, or I'm going to use e-stim, it's going to make the muscle pump, is completely opposite when we put a needle in the tendon, whether you're fenestrating the tendon or twisting or placing or using e-stim, because we're not going to generate a contractile response. So I create that, or I paint that picture very specifically because I'm first going to jump into the case against tendon needling. And I will say again that tendon pecking, that fenestration, that micro trauma approach was based on research. But I'll tell you, most of it is animal research. So they're fenestrating these poor little rat tendons. First of all, they're typically healthy tendons, and second of all, again, they're animal subjects. So really, they're just looking at what is the histological cascade, what happens blood flow wise and physiologically. Depending on who you were trained through, there was a study done in the early 2000s, maybe late 90s by Kubo, Kubo, where they went in and, pretty brutally jackhammered the Achilles tendon. What was cool is they didn't just see blood flow changes at the Achilles tendon. They saw a massive vasodilation and blood flow response in the entire triceps surae, so entire gastroc soleus complex. And they compared that to just putting a hot pack on gastroc soleus. And it lasted longer and is more profound from the needle. So again, people didn't just start fenestrating tendons because they, I guess, investigationally or experimentally, they had research to say, okay, when we peppered this tendon, either we got a massive blood flow response, which at this point we know is an autonomic nervous system, a vasodilatory response, super cool. Or they said, okay, when we peppered this collagen of a tendon and put it under a microscope, day 0, day 1, it looked pretty bad. We beat up the tendon. But then day 1, day 2, into day 2, day 3, it actually remodeled itself. It matured and it became a healthier looking tissue. So that was really what created that initial, more mechanical dosed tendon needling. Here is why there's less of that now, or really why that um, contextual model doesn't hold up well. First of all, in the clinic, we're probably not needling a healthy tendon. So first of all, if whether it's animal subject or not, when you look at a healthy healing response, a healthy collagen resynthesis response, that's a healthy tissue, a healthy subject. Typically, when we're using needles in the clinic, we're on whatever aspect of the spectrum of tendinopathy, tendinitis if it's acute, tendinosis if it's degenerative and more chronic, meaning we are traumatizing a tissue that already has either degeneration, it's not a healthy, mature, resilient tissue, or it already has an inflammatory response that the body is not managing well. So the rationale that we're going to go in and create more inflammation and prompt better remodeling in a deficient structure seems to not hold up well. What parlays that is that it's not as comfortable for the patient. Some of you can probably imagine, even the discomfort of an achy, crampy, sore intramuscular needle. As the clinician, we can't get our needle very deep. It's a sticky, gummy tendon collagen. So we're not getting as deep, but it's also a much more sensitive tissue for our patients. So the combination of really how much good are we doing based on that original research and the patient experience is why we're not seeing as much of the tendon fenestration as we used to see. Um, with all of that to say, there are a few there's very small windows within tendon injury where that still makes sense and it still might be appropriate. So really that's the case against it. I'll come back to patient experience at the end is what good can we do by mechanically insulting or even in a therapeutic mindset, mechanically traumatizing a tissue that is already having dysfunction. Again, whether you want to say there's an active inflammation, there's degenerative changes, is what good can we do by directly hitting that tissue with the needle? And again, I'm not saying don't use dry needling, but sometimes we have to weigh what is the benefit for that Achilles tendinopathy to putting needles directly into the Achilles versus gastroc soleus, maybe posterior tibialis. So maybe we do go after the more muscular targets. One more, I guess, ration or explanation that really drifted me personally away from direct tendon needling was actually at a conference years ago. At this point, many years ago, 7 or 8 years. Jill Cook, the tendon guru from Australia, wasn't talking about dry needling at all. She was giving her talk, fascinating discussion, learned more about the Achilles tendon in 2 hours than I had my entire PT education. She's talking tendinopathy. And really before she went into like tendinitis, tendinosis, tendinopathy, she talked about this is a healthy, pain-free, if you want to say that, but a healthy Achilles tendon. There is not much neovasculature or angiogenesis potential to the mid-substance of the Achilles. Meaning, if we're looking at the cross-section of the Achilles like this, there aren't these deeper venturing vessels to supply nutrients and blood flow mid-substance of the Achilles. It is one of the most cylindrical cord-like tendons in the body, and we have lots of high torquing force going through the tendon, which is why Achilles tendinopathy can be unique to other tendinopathies and frustrating clinically. But her explanation is there's really not much vascular support or nutrition going mid-substance. Almost all of the blood flow lives in a very thin peritendinous film of the Achilles. And again, she was going nowhere near dry needling with this discussion, but this is in my mind when I'm like, oh, my goal by putting a needle in the mid substance of the Achilles partially was blood flow and angiogenesis. Again, maybe this tissue is already struggling to deal with inflammation or degeneration, but this tendon guru, I mean, she's an expert in tendinopathy, is telling me there's really there's not much therapeutic potential for angiogenesis to mid substance. So again, for me personally, combining knowing how uncomfortable it could be for the patient for me to go in and manipulate a needle in their tendon, and now seeing that maybe the potential for blood flow nutrition mid substance wasn't there, is when I personally stopped putting as many needles in the Achilles tendon. Now I'm going to end this talk by saying I'm starting to needle more tendons, but it's not with a mechanical disruption. It's using e-stim, or it's just leaving a very superficial static needle. But that's the case against tendon needling. You heard me say partially it's patient comfort. It is a more uncomfortable needle. Typically, we're treating tendons in humans that are less healthy, already active inflammation or already some degeneration. So can our needle add insult to the injury? When I shift over, I'll tell you there's really low risk to that. But again, maybe the therapeutic potential isn't what we used to think it was. So that's the case against tendon needling. And again, to reinforce that even the narrative, everything else we say about using a needle in muscle, intramuscularly, generating a muscle spindle response, is exactly different. So we need to change the narrative or the rationale to our patient if we're going to needle a tendon. If I jump over and now play devil's advocate or point counterpoint, here is the case to needle tendons. And it might surprise many of you out there to say that the research data set at this point supports tendon needling. And there's actually quite a bit out there. I'm gonna research vomit in a second, but if you do a thorough analysis of what's out there of putting needles in tendons, and you'll hear in a second that a lot of it is comparing a dry needle in a tendon to injection or injectables into a tendon, dry needling does pretty well. So that might surprise some of you, and maybe that depending on how you treat or who you treat, maybe that research vote means more to you than others. But here's what it looks like. And really, I'll tell you, the higher level, the less biased, and the more recent research is what supports tendon needling. So again, just to run through some of these, if you want like the actual citation, send us a message or send me a message on Instagram, DPT with Needles on Instagram. So 2022 systematic review done by Georgie supported dry needling, moderate level confidence, but supported tendon dry needling. Basically saying current evidence supports use of dry needling for various tendinopathies, and that is even better when we combine exercise. Cool, pretty agreeable. And there's moderate confidence there. In 2020, there was a narrative review. This was a little earlier. So they said, the early support supports tendon needling, but at the very least, what they were saying is it's minimally invasive, it's safe, it's inexpensive, and it carries a low risk. And again, they're comparing short-term, long-term impact of dry needling versus injection therapies. So 2020, 2022, we have narrative and systematic review support. 2007 in the BMJ, they did ultrasound-guided dry needling versus PRP for patellar tendinopathy, and there was no difference between the two groups. There was 2014, a case study, JOSPT, they did high hamstring dry needling. Case series, 2 subjects, but there was benefit, there was support there. And I think the most intriguing one that I'll end with, supporting the use of dry needling, was ultrasound-guided dry needling to the lateral epicondyle, the wrist extensor tendon, and they compared it to open release surgery. And maybe I'm preaching to the choir, but it is incredible to say there was no difference between those groups. So half of them went in and just had, they used ultrasound just to make sure that their needle was in the tendon at the lateral epicondyle, but it was comparable, similar outcomes, especially a year and 2 years down the road, to open release surgery. I mean, that's a mic drop moment. And again, I'm preaching to the choir here, but I've already said that dry needling does pretty well. It actually is on the same level, or if you consider some of the negative impacts of injections, dry needling does pretty well, if not outperforms almost every type of injectable therapy. And typically that's PRP, cortisone, or something else, but something else that likely has a longer detrimental negative long-term impact. And we also have that one RCT, and it was 2022 by Bureau et al. That said lateral epicondylalgia, open release surgery versus dry needling, no difference. That's profound. And again, if you're saying no matter how much you subscribe to evidence-based practice or saying I need evidence or research to support what I'm doing, you have the research support for tendon needling. You have research saying it's safe, that there's no really detrimental impact, whether it's like an acute needle injury, it's not going to happen, or if there's long-term detriment to needling a tendon. The answer is no, based on research. And research also says there's benefit. Now, to be fair, again, I'm doing case for and case against. Not all research supports tendon needling, but this is still on the case for using needling. Even the research that says there wasn't really a difference with dry needling, again, held up well against injectables. There was a 2012 where they did PRP. PRP outperformed dry needling to the supraspinatus tendon in the short term. So I didn't write it down. I forget if that was a month or less, but in the short term, PRP for the supraspinatus tendon outperformed dry needling, but longer term, about the same. So if that's the most negative research we can find out there about tendon needling, that's not that bad. Second one there, they were doing the Achilles tendon and basically just said there's no difference between PRP and dry needling. And it actually, why I put it in the kind of case against is it said that there was benefit for dry needling in some of the subjects, but not in others, versus the PRP showed some sort of benefit in all of the subjects. So again, the conclusion there, that's a 2019 article by Michelle Abate, Achilles tendon dry needling, basically said, if your options are PRP or dry needling might help. It helps some of the subjects. PRP definitely helped to some degree every subject. So there's kind of a quick and dirty 2-minute research appraisal on where we sit. But considering all of that, considering the high level of evidence, and considering that dry needling is at least the same and likely better than injectable therapies or even surgery, that's a huge vote in support of tendon dry needling. And that was a pretty general, I didn't get into too much of the methodology. Most of those were either statically placed needles or it was the mechanical fenestration of the tendon. What we're not seeing much yet, and I think I'm going to end with this, we're going to see more e-stim use in the clinic with needles across the board. And for me, that's going to include tendon needling. So as I wrap this up, I kind of gave you the case against dry needling tendons. It's less comfortable. Our narrative of intramuscular responses goes out the window. And the research that initially supported it might not be as sound as we thought, which is collagen resynthesis angiogenesis. I gave you the case for needling, which was honestly pretty easy. All I did was tell you resounding support from research out there. High level support does better than injectables. So here are 3 things to consider, because I told you I kind of was trained in tendon needling initially. Then I kind of stopped almost completely based on that interaction or that convention topic on Achilles tendinopathy. And now I'm starting to use it more. So here are really three things that I consider. Am I going to put a needle in a tendon or not? Number one is the patient. That's the obvious one, but that's the most, to be as specific as I can, the few patients that I slowly started using tendon needles in tendons, to be completely honest, partially was based on their request. They had had tendon needling before. They thought it benefited them, so they requested it from me. And a lot of times I was doing all of my E-stim, my intramuscular stuff, and I snuck a few needles in the tendon because they thought it helped. So the patient value has to be considered. If they see value in it, there's really no harm in just putting a needle in the tendon. And again, I would explain is like, okay, this one's going to feel a little different. Everything else is achy, crampy, sore. It might twitch. It's going to like pump with E-stim. This one's not. It's going to feel kind of sharp. It's not going to be very deep, but even if I stim it, it's just going to feel like a more superficial shock. But that's okay. We're still getting nervous system input. We're getting a little bit of engorgement of that peritendinous film. That's all good stuff. So we have to kind of massage our narrative to the patient, but also saying the patient is the number one thing I consider. There are some patients, and for those of you who needle right now know, there are some patients that you're like, yeah, I'm probably not going to put a needle in this patient's tendon just based on their sensitivity. I mean, based on their uh, acuteness of their condition, but their sensitivity. There's some patients where I'm like, yeah, we're not going to do a tendon needle. And maybe we're not even going to use needles at all, but that's the kind of patient I'm picturing. Second thing I consider if I'm going to put a needle in a tendon or not is the stage or the condition of the injury. Is this that relatively acute? They jumped into a 20-mile-a-week marathon training program from the couch and they flared up their Achilles or the patella. Is there acute onset there? Or is this that 1, 2, 10-year-old tendinopathy where I can palpate, I can picture, or I can just visualize tendinosis changes. It's thickened. There are tissue quality changes. There's not an active inflammation. That second one, I will much more quickly go after with a needle and E-stim. The first one, I think there's other variables we can apply, or we can use our needles in different regions aside from putting a needle into an acute inflammation. And the last thought, three things to consider. It's the patient, the stage or the condition of the injury. And number three is where is the patient in their life, I guess, for lack of a better word. Meaning, did this just kind of pop up this week and they're like, oh, this is kind of bothering me. I thought I'd come see you and get ahead of it. Versus, man, doc, I'm coming to see you. I'm paying you out of pocket because I've seen 3 PTs, a Graston chiropractor. I've done acupuncture. I've heard you do something different. So I am here to try something because otherwise I'm going back to get my 4th injection and have surgery. That patient, I'm like, you know what? Let's try needling. Whether visit 1 we do tendon, or let's start with some of the muscles that influence a tendon, and ultimately maybe we wind up in the tendon. But that patient where I'm like, they're telling me that if they're willing to try anything, but if they're looking for any other option aside from pharmaceuticals, injectables, or surgery, knowing how safe it is, I see there being no risk there. I'm like, thank you for finding me. Thank you for trying this first. Versus again, that first one that's like, oh yeah, it's kind of weird. This popped up. I think there's other things we can do aside from like, all right, lay down. I'm putting a needle in your tendon. So that's where I sit. 3 things to consider. And really, again, I guess to put the final thought on this, I think I give this kind of explanation a lot on every course I do, but dry needling at this point is a big umbrella term. So really you have to define what you're doing with the needle. And really that's a patient saying, I've had dry needling and I liked it, or I had dry needling and didn't like it. You kind of have to tease out like, well, what was it like? Did they just place needles? Did they spin them? Did they piston them? Did they use E-stim? Even the mini umbrella of tendon needling is the same thing. It's like, oh, you had a needle in your tendon before? Like, what was it like? Same questions. Did they piston it? Did they stim it? I think we have to ask those questions because the narrative changes. I guess the approachability changes as far as patient comfort. And also your outcomes are going to change. And my final thought here is we're going to start seeing more e-stim in tendons. There's not much there in research. There's a few like percutaneous electrolysis, which is kind of similar, but not. But I think what we're going to see is more tendon stim. I don't have research to support this. It's just my own recent use, but also colleagues that I trust. They see high-level athletic populations. They're putting needles, patellar ligament, I guess, the lower patellar attachments. They're putting needles in the patellar fat pad, and they're using e-stim. And again, it's a different sensory experience. It's not going to pump. It's going to feel different, but there's anecdotal benefit there. So again, I do think there's value in saying, or maybe ultimately to the patient saying, we're going to go to ground zero here. Like this is an unhealthy, inflamed, degenerated tendon for whatever reason, or there are some things that we can address directly with this tendon. And again, patellar tendonitis, Achilles tendonitis, lateral epicondyle seem to be the highest. I think you can apply similar to rotator cuff tendons, pubic attachment tendons, and even to some degree, if you're not seeing success with muscular needling for low back pain, there are techniques where you go in and get the thoracolumbar attachments at the sacrum and the ilium, or even some of the ligaments of the iliosacral region. So that's where I conclude. I mean, really, I'm trying to give the case for or against tendon needling, but if you are trained in needling, what you probably grasp from this discussion is one, that it's safe, two, that it's probably a better option than what they might pursue if they don't want a dry needle, and that's injectables, surgery, medication, and three, that research supports it. So if you are trained, that almost gives you a license to try it out. I think the encouragement would just be selective with your patients. Continue to do what you normally would do. Like we know tendon loading is more important than anything else. So this is not, it's an and not or kind of a situation like it always is. And lastly, I'll just plug what we're going to do. Like we have an advanced course coming in 2024. We're going to put needles in tendons and we're going to use e-stim. And not to give away all of our secrets, but it's a little less on what's happening to the histology, the tissues local to the needle, and it's more about nervous system impact, or maybe blood flow changes, but not local blood flow changes, autonomic blood flow changes. So we'll needle tendons in our advanced course. We'll approach nerves with e-stim, and then we'll treat some of the higher risk needles, higher risk muscles with a needle. So that's what's coming in 2024. Otherwise, I'm going to wrap this up. Again, I'm Paul Kaloran. If you have a direct question or you want some citations, at DPT with Needles. We are really excited to be out on the road a lot this year. We have courses all over the map. So whether you have your training but it didn't have much e-stim, or you're wanting to add needling to your practice, we'd love to see you on an upper body or lower body ice dry needling course. Thanks for joining, squad. I'll see you guys soon.